Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're going to look at the difference between a placenta previa and a placental abruption. As always, let's dive in with our practice question. We have a nurse reviewing the charts of 4 third trimester clients. Which assessment finding is most consistent with a placenta previa diagnosis? We have A, the sudden onset of severe abdominal pain with a firm, tender uterus and recurrent late decelerations. B, painless vaginal bleeding with a soft, non-tender uterus and a reassuring fetal heart rate. C, dark vaginal bleeding after minor trauma with frequent contractions and fetal bradycardia. Or D, minimal visible bleeding, severe back pain, tachycardia, and a rigid uterus on palpation. Okay, 4 different presentations of bleeding in the third trimester, and they all tell a different story. So think about what is placenta previa and which of those stories tells that picture. We will now dive into exactly what that placenta previa is, and hopefully by the end of the episode, you will totally understand the presentation. First, though, as always, you guys know me, I like to kind of zoom in on the anatomy and pathophysiology so we know what is happening with our signs and symptoms. Obviously, with placenta previa, we are talking about the placenta, and that lives inside the uterus. I want you to picture the uterus, honestly, as like a muscular house. It's got a front, back, walls all the way around, big doorway at the bottom. The doorway of this house, our uterus, is the cervix. And that's where the baby is going to eventually, make its exit. But inside that house, all the way at the back, is the placenta. And it acts like a life support system for the baby. It's like the generator of this house. It's going to anchor into the uterine wall and basically tap into mom's arterial system so we can get some of that blood flow coming from mom over to the placenta and eventually to baby. This creates a massive vascular interface where we can exchange oxygen and nutrients and waste products. All of this can get traded back and forth. And the placenta, like I said, it should be at the back of the house, that upper portion of the uterus, very far away from our big doorway at the bottom where baby's going to make its exit, the cervix, okay? Because the cervix, eventually, towards the end, is going to start to thin, that's effacement, and open, that's dilation, so that baby can exit the uterus out of the birth canal. Now, if that placenta is in the way of our door, that is going to be a problem. Placenta previa is all about location. If we've got a placenta implanting too low, near, or directly over that cervix, we are literally blocking the door. It's like we have parked that generator right in front of the doorway. Honestly, in early pregnancy, it is not that big of a deal. But as the uterus stretches and the lower uterine segment starts to thin, that lower airway, it does not have as much sturdy muscle in that interface between placenta and uterine wall. Remember all those vessels and that exchange of nutrients. It's starting to get tugged on. It's starting to shear. That tissue is really highly vascular. So we can start to get some bleeding going on. All right. That's the first key thing we're going to think about with a previa. We have some bleeding. What does that bleeding look like? This is the key. It is usually really fresh, bright red blood. It's not from like a big arterial tear. It's more like kind of peeling a very vascular sticker off a wall. So we get that really bright red blood coming from the site where the placenta is attached. Usually the uterine muscle itself isn't really contracting. It isn't really super irritated. So it's not going to be like painful and hard and, tender. It's usually a soft, non-tender uterus. And we've just got this placenta that is shearing off and causing this bright red bleeding. Okay, so this is kind of the typical symptom set I want you thinking of. Mom's not complaining of pain. She's not cramping. She's not like, oh my gosh, I can't even speak. The bleeding comes on suddenly. It's quite noticeable, but it's not causing her a lot of pain. It is that bright red, painless third trimester bleeding with a soft uterus that is the classic picture of placenta previa. And why is it happening? The placenta's in the wrong spot. It's starting to kind of shear off, and it's real vascular, so we get that bleeding. Now, let's contrast that with our second way we can get bleeding in the third trimester, a placental abruption. Okay, you already know the normal anatomy of placenta. It's in the house of the uterus, towards the back. And in an abruption, the placenta is usually in its normal spot. It's not blocking the cervix. It's not implanted in the wrong place. The problem that happens with an abruption is that it separates prematurely from the uterine wall before the baby is born. This should be a big red flag. This should be making you so nervous right now because remember, that placenta is embedded in the uterine wall so that we can have that vascular, meshing where we're sending oxygen and nutrients back and forth across the placenta. If it pulls across from the uterine wall, we can't do that anymore. What's more is that the uterine wall, that, thick muscular uterus, it is rich with arteries. Remember, it's kind of plugging into mom's spinal arteries, and those are under high pressure. So if all of a sudden that placenta tears away, maybe it's because of trauma. Maybe it's because we've got chronic hypertension. Cocaine use can cause this. It can also be caused if we have a really quick loss of fluid. We lose that amniotic fluid that kind of pulls that uterus or pulls that placenta more like it, and it can rip it off of the uterus. So whatever the cause, if it pulls and separates, we now have an arterial bleeding directly into the uterus. Now, two different ways that this can present. We can get a hematoma forming behind the placenta, and then that blood doesn't escape immediately out of the cervix. It's concealed or occult, might be what the terminology is. So that bleeding is happening, but essentially it is staying in the uterus and it is concealed. It's internal. She's still losing a lot of blood, so this is still a really big issue. We are just not seeing it. Now, the other way is if that hematoma doesn't immediately form behind the placenta, that blood does escape out of the cervix and it is revealed, and you can see dark red gushing blood. So whether you can see the blood and it's revealed or you cannot see the blood and it's concealed, mom is bleeding a lot, and the uterus responds by clamping down in a sustained contraction to try and cut that blood flow off. This is what it should be doing. This is the appropriate biologic response. We are clamping our vessels down to try and stop a bleed. But that means on assessment, we are going to have a uterus that is firm, painful. The word that you usually see on the NCLEX is a board-like uterus. It is not soft. It is so hard, so tender. It is like one chronic contraction instead of those contractions that, normally they kind of come in waves, right? Because it's trying to clamp down on those arteries that are bleeding. Now, I am very worried about mom in this situation because she is losing blood. She can go into hypovolemic shock super quick. I am also very, very worried about baby because if we no longer have a placenta attached to the uterus, we don't have that blood flow. Mom's blood supply equals baby's blood supply. So we now have fetal oxygenation at risk. They are going to have late decelerations, bradycardia, minimal to no variability, all of those non-reassuring fetal heart rate patterns because that baby is not getting enough oxygen anymore. So if we boil it down to like compare and contrast here, previa is about location. Placenta is blocking the door. We are covering up that cervix so baby cannot exit. And as that baby grows, we got pressure, we got shearing, we get some bright red, painless bleeding. It's not hurting. Mom's uterus is non-tender. We just got some bright red bleeding. On the other hand, abruption is an attachment problem. The placenta tears away. We get dark red bleeding and a board-like tender uterus. That baby is distressed. In previa, wrong location, we're not in distress. Abruption, we're detaching, we are in distress. Okay, you got it? So we went through 2 different ways that we can present in the 3rd trimester with bleeding today. I'm not going to go through a clinical scenario since we've already kind of compared and contrasted 2 different situations. We are going to go right into this practice question because now I want you to be able to pick out the client that is most suggestive of each of these presentations. So again, I'm going to read you off 4 options here. And we are going to pick out the client that is most consistent with a diagnosis of placenta previa. Are you ready? Okay, is it A, the mom who has sudden onset of severe abdominal pain with a firm, tender uterus and recurrent late decelerations? B, the mom with painless vaginal bleeding with a soft, non-tender uterus and a reassuring fetal heart rate? C, the mom with dark vaginal bleeding after a minor trauma with frequent contractions and fetal bradycardia? Or D, minimal visible bleeding, severe back pain, tachycardia, and a rigid uterus on palpation? What do we think here? Think back to what's happening in the anatomy and physiology. I literally always go back to the A and P. In placenta previa, we've got a location problem. That placenta is over the cervix. We are blocking the doorway. Baby cannot make its exit. We have some shearing. That's what's causing the bleeding. So is she going to have abdominal pain? No. A is out. Is she going to be having those frequent contractions, those non-reassuring heart rates? No. C is out. Is she going to have a rigid uterus on palpation? No. D is out. A, C, and D, we have all got contracting down, baby in trouble, rigid uterus, and that's not what happens in previa. So the correct answer is B, that painless vaginal bleeding with a soft, non-tender uterus and a reassuring fetal heart rate is your classic picture of placenta previa. That placenta is in the wrong location. We get some bleeding as that lower uterine segment stretches, but it's not majorly irritating. So that uterus, it stays soft, non-tender. They are not in severe pain, and the baby is still well oxygenated. So they look okay. In our other options, when we've got that sudden pain, a firm, tender uterus, late decels, when we've got trauma, contractions, bradycardia, when we have a rigid uterus, we are thinking about a placental abruption. It's not a location problem. It is the fact that that placenta is detaching. Mom is at risk for shock. She's got dark red bleeding. She is in a lot of pain. The buzzword you want to look for is that board-like uterus because it is clamping down in one consistent contraction to try and cut off that bleeding. And because that placenta is tearing apart from the uterus, we are no longer oxygenating baby nearly as well. So we are going to see late decels. We are going to see fetal bradycardia. We are going to see that change in variability, all those non-reassuring things. Okay, those are 2 of the different ways you can get bleeding in the 3rd trimester. We have compared and contrasted all the differences between that placenta previa and that placental abruption. You have got to know how these present because you manage them very differently. With placenta previa, the takeaway that I have for you is that we don't do a cervical check All right. We don't want to poke anything up in that cervix that could irritate it further and worsen the bleeding. Okay. So a cervical exam is contraindicated, and that's the big thing you're going to be tested on for placenta previa. Otherwise, mom needs to go on bed rest, be well hydrated, do pad counts to monitor the bleeding, and they're typically going to be delivered via a C-section. Because remember, our door is blocked. We can't really exit the vaginal canal, so we got to go the C-section route. In placental abruption, we're also going for a C-section, but this is an emergency. The only thing you can do for this client is push them straight into the OR. They're at risk of shock, so monitor that mom's blood pressure and monitor her heart rate. She is likely going to need fluid and or blood products based on how much she is bleeding. Baby is in distress, so we want her on that monitor. The only thing we can really do is deliver that baby ASAP. We can't fix this problem while baby is still in utero because they ain't getting the oxygen that they need. So emergency C-section and get that baby out. And that is your difference between placenta previa and placental abruption. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.